As I said, I'll make a shopping. Good morning. This is January 16th. Yep. And the Senate Health and Welfare Committee. And this morning we're going through a number of bills that we have in our committee that we have an interest in. And the first one is S-241. And we have the two co-sponsors here. So I will ask you to introduce yourselves and then tell us why we have this bill.
Senator Jenny Vyhovsky from the Chittenden Central District.
Senator Martina Kulik, also from the Chittenden Central District and Vice Chair of this committee. So nice to see all of my colleagues here.
So Senator Kulik and I are introducing S-241. It came to us from the National Association of Social Work. And it came to us because of concerns about AI providing therapy to people and some of the, frankly, really awful things that have happened in other places due to that. There have been, AI is really meant to engage in a way that is affirmative to what people are saying. And some of the things that I certainly know I have heard is there have been instances where people have been talking to AI, particularly around feeling suicidal, and the AI's response, because it is meant to be affirmative, is, yeah, you should do that. Because it's not a human, it's not responsive to human emotions. It's simply meant to kind of give positive response back. And so if you say, hey, I really want to do this thing, the AI, rather than thinking about what, because it can't think, just affirms. And so really dangerous things can happen when we're allowing algorithms to work with people who are in mental health distress or mental health crisis. As someone who does that work, it takes a lot of deep thought and a lot of real connection that an algorithm simply can't provide. So this bill proposes to prohibit in the state of Vermont any entity, whether that is a person, a corporation, from providing therapeutic services utilizing AI.
Yeah, I would just add, both Senator Vyhovsky and I have worked in schools. We spent a large part of our careers working with young people. We understand that mental health needs have been on the rise, especially since COVID. So we certainly understand the pressures, and we understand that folks are grasping at, anything they can get to help the situation, which is frankly, as we all know, caused increases in spending in schools. At the same time, the safety and the health of our young people is absolutely the most important thing that we can assure in anything that we're moving forward with. So that's why I think we're both extremely interested in this bill.
And young people are particularly vulnerable to this type of engagement, that given the lack of development of their prefrontal cortex, they are in a particularly vulnerable space to not be able to really differentiate necessarily in those moments of crisis that this is not a real human being. Yes, they logically know this, but what we know about the prefrontal cortex is that it inhibits the manner in which we process information under what's known as hot cognition. So in a crisis moment, someone with an underdeveloped prefrontal cortex, because they're young, simply cannot process the impact of what is being said and the long-term consequence of how they may act because of that. And so for that reason, I know we both believe that AI really has no place in providing direct mental health treatment. I can't remember if it's in this bill or another bill. There is places where AI might be useful in therapeutic services, perhaps transcribing notes or really perhaps transcribing notes. I really already got probably the only place. And even then,
And I think there is another AI bill
Yes.
related to that coming over from.
yes, and that should be done with informed consent. Again, just because we need to really be careful about how we're protecting everyone and how we're investing in supports and services that work and are responsive to those needs.
Terrific. Thank you both. Questions?
So one question, you mentioned youth, but I don't believe, as I scanned the bill, that it's limited to youth, right? It's all service. Yeah.
AI really, it's dangerous for everyone, but because of youth's brain development, it's particularly dangerous for youth, but it does prohibit it in all instances, yes.
Good. So question, so you had talked about, came from the social work group, and then obviously a lot of counseling there. This is also include mental health counselors.
It includes
I
all
will
use
say
of
I
AI.
showed it to my daughter, who is a mental health counselor, Mr. Trumbull, and she said, "This is great."
Oh, good. Good, that's what we want to hear. That's great.
Yeah, I think there's a lot of, I mean, the profession, I think, agrees with that, from the treatment perspective.
And the way this has rolled out in other places, it's not licensed professionals that are utilizing AI to provide therapy, because I think any ethical licensed professional understands that that is unethical and dangerous. It's larger corporations that are going in, frankly, to just make money off of people suffering.
No, we have enough of them. Okay. Thank you. Anything else that we should know about this?
Now I think Katie's gonna run through the bill with us and yeah, thank you.
Sounds good.
Thanks for listening.
And if we combine this with vaping and nicotine and we really stunt the prefrontal cortex and cause impulse control loss, and we have a compound fracture.
Yes, yeah, that's very true.
Well, thank you.
Thank you.
All right,
Thank you. Thank you for taking it up so early in the
information
session.
for us.
Yeah, we are moving.
Katie, you get the uncomfortable chair.
Sorry, I'm Katie, unless you want that.
I remember that chair. Can you measure the size of that chair?
Good morning, Katie Midland, Office of Legislative Counsel, and I pull up the draft. So this morning, I know you're looking at a lot of bills and you are looking for sort of the very high overview of each of these bills. So what I will say is that there is a lot more ground to tread on this particular bill that I'm going to cover. Particularly, I think the definitions are pretty dense and there's a lot to unpack there. But just for the purpose of the high level overview, this bill, as you heard, says that a person, a corporation, or an entity shall not offer, provide, or advertise mental health services in the state that use artificial intelligence in whole or part. And then there are some exceptions. There's also language specific to mental health providers. It prohibits a mental health provider from using artificial intelligence to make therapeutic decisions. Issue direct therapeutic communications, which is a defined term, generate treatment plans, or to detect or interpret emotions. It also prohibits a mental health provider from offering, providing, or advertising mental health services that use AI, but with two exceptions. The first you heard about earlier, which is transcription and recording of patient or client conversation and counseling, but that can only be done with informed consent. So that is outlined in the bill. The other exception is to provide administrative support services to the professional, so long as that professional reviews the AI administrative support services that are being provided, any outputs that come of those services, any tasks performed by those services, and ultimately takes responsibility for those AI administrative outputs. So in a nutshell, that is what this bill does. We can sort of, I know you don't want to get into the language too much, but I'll just kind of give you a flavor of how this is set up. So you have a finding section, and we can go over that in more detail when we take up the bill again. You have a purpose section. And then you have a section under unprofessional conduct. That it would be unprofessional for any mental health professional to misuse artificial intelligence pursuant to 267101, which is a new section created in this bill. And then in Title 18, we have language about the prohibited uses of artificial intelligence. Within that, we have the definition of artificial intelligence. I will note that I have had so many conversations with my colleagues about the definition of artificial intelligence, because lots of committees are looking at the issue of artificial intelligence in lots of different contexts throughout the building. And I don't think there's been a decision on one is there one definition of artificial intelligence? So I will just flag that, not just for your conversation here, but throughout the building. What do we mean when we say artificial intelligence? We have a definition of mental health services. We have a definition of therapeutic communication. This is just a cross-reference. The longer definition is elsewhere in this bill. Then we have our language that I started off with that prohibits a person, corporation, or entity from offering, providing, or advertising services, mental health services that use AI. And then we have violation language that's tied into a violation of the Consumer Protection Act. And let's see that. At the top of page 5, we have another new set of language. The previous language we were looking at, it was in Title 18, that's the health title. This is in Title 26, which is the regulation of professions title. So we're creating a new chapter here called Artificial Intelligence and Regulated Professions. The idea being that this might not be the only profession where there's legislation at some point on artificial intelligence. So we're creating a new broad chapter where this could fall under. We're using the same definition of artificial intelligence that was used up above, and then creating a new subchapter that's specific to mental health professionals with regard to the use of artificial intelligence. And then this is the language that is specific to what mental health professionals, how they can use artificial intelligence and what is prohibited. So we have a definition of administrative support, consent with regard to that transcription service. We have a list of who is considered a mental health professional. It's a long list. So like I said, there's a lot to unpack in the definition section.
We probably should have OPR in to help us with all of this too.
I'm sure they would have comments. We have a definition of mental health services that was reflected up above. Here is the longer definition of therapeutic communication. Previously in the bill, it was just cross-referenced, but here's a much longer definition where it's laid out. We have a subsection on the permitted uses of AI by mental health professionals. And these are the two items that I already chatted with you about, which is the administrative support and the transcription and recording services. We have some language about confidentiality with regard to those transcription services or any administrative support tasks that use AI. And then we have prohibited uses. And again, this is what we already covered, which is not using, a mental health professional cannot use AI to make therapeutic decisions, issue direct therapeutic communications, generate treatment plans or recommendations, or detect or interpret emotions or mental states. And also they can't use it to provide, offer, advertise mental health services in the state, except as provided up above. And the bill takes effect on passage.
There's a lot in there.
So there is a lot. I know when we do a longer walkthrough, we'll want to really spend more time with the definitions.
Okay. And do we know if other states are looking at this?
Oh, I believe so, yeah.
Yeah, they're looking at it.
Yeah, if you want a summary of who has passed what, I would have to pull that up, but I know other states are looking at it, and I would imagine there are a few other states who've already acted on it.
Okay, that would be good. Maybe we can check in on what they have for something.
Yeah,
stuff.
I'll make a note of that.
The other question, how is this enforced?
We have language that ties it to the Consumer Protection Act. Well, twofold. So the AG.
Yeah.
So the first part where it talks about a person, corporation or entity shall not offer or advertise, that is the Consumer Protection Act. So AG's office. Second part of the bill is OPR. So it's tied to somebody's mental health professional's licensure through OPR.
Okay.
I thought I saw civil penalty.
Yep, that was under the Consumer Protection language.
Okay, that's $10,000 or something like that.
Yeah, where is that? Right
Oh.
here. So this is like sort of standard language on the Consumer Protection Act that appears throughout the VSA. So that's where this has been pulled from, ties it to the Consumer Protection Act. Attorney General has the same authority to make rules, conduct civil investigations, enter into assurances for discontinuance, bring civil actions, etc. So, yes.
That's it.
A question. So, I can understand where this is trying to go, but my question would be if you're a provider and you have a client comes in and you used AI to query similar cases to give you some background on how treatments or successful treatments have been administered in other places. Is that allowed? The AI is not actually administering the treatment or directing it, but it's being used by the professional to get background information that may be helpful in actually providing the care.
Yeah, that's a good question. I think it will come down to what we have under the definition of therapeutic. Oops, that what I wanted to have.
And we'll bring in
Therapeutic communication. No. I think the short answer is if there is a person who is a licensed professional who is doing research and ultimately is responsible for making the therapeutic underlying decision about a treatment plan, then that would be authorized. I think it's when AI judgment is substituted for a licensed human professional person where this bill would be drawn the line in the sand.
What I would assume, it's just that
That's right. Yeah.
scan it wasn't quite
Yeah.
clear.
Yes, it's not clear.
Yeah, so we'll do the deep dive, but that's a good question, and that's one that we'll hear from folks about. Anything else? But I know there's a companion bill to this in the House. It will be an interesting, and we haven't made a decision. Is it starting here or there? I'm just giving us all a heads up, but we're gonna keep working on it, because it's a really important topic. I do have one question. So how do we distinguish, how does anyone distinguish between the chat application and AI therapy? Would chat be included in that? If someone who had suicidal thoughts started talking with the computer?
So it's an entity that is providing a mental health service, if it's providing.
Well, if it's not defined as it, so chat's not defined as a mental health service, it's just, is it? It's a conversation. So this is something we're gonna have to sort out maybe with somebody who's in charge of that one.
That's a really good question.
There we go.
Yeah.
I know, I worry about it a lot because then, I can't go talk about my mental health problems here, but I can have a nice conversation with the computer.
Yeah.
Tells me to go do what I shouldn't. Yeah.
We had a little conversation about that in institutions yesterday, and as I understood it, there was a bill that was passed last year that protected at least children in
Yes.
that.
Yeah.
Let's start that.
Okay, good. So we don't have. Oh, I'm the sponsor of the next one. We can just go right ahead with it. Right? Okay, yeah. We're doing S-157, an act relating recovery resident certification. Actually, the lead sponsor is no longer in the Senate, and but we're going to take this up anyway because a lot of work has been done outside of the building on recovery resident certification and looking at a systematic approach to recovery residences. This committee began the process 2 years ago or 3 years ago with S-186. Forgot which one. Anyway, we've done a lot of work in this area. So, and we did have testimony recently about the different levels of recovery So it's, you know, the acute level for toxicity and then down, stepping down, and into the residential facilities. And one of the things we did last year was to expand the number of days that someone could stay in a residential facility and be covered by, insurance. And then there's a lot going on outside in the real world with, trying to fill the gaps. You know, so Jenna's Promise does one thing and we have other places doing other things, whether it's Valley Vista or Serenity House or, you know, just, so we're trying to get our arms around all of that, the licensure, the certification, who's there, who's doing what, is it a peer support facility? So that's where we are, I guess. Oh, you'll tell us that. You'll tell us where we are. Yeah.
Okay, let me pull this one up.
And we know we need this desperately. Really do.
Okay. This is S-157, our recovery residence bill. Yes, there has been a lot of work in this area. There has been previous legislation in this area, particularly around how a recovery residence is and is not like a regular rental agreement. And particularly with regard to when somebody can be removed from their recovery residence. That language is set to sunset. That previous work that the General Assembly has done is set to sunset July 1, 26, and this bill removes that sunset. So we can look at that. But in general, this bill allows a recovery residence in the state to request a certification from the Department of Health if certain criteria are met, including that there's a long list, but items like that they are already certified by VTAR, Vermont Alliance of Recovery Residences, and that there is a process in place in the recovery residence for any complaints about how it's operated. There's language in here requiring the health department to establish rules, and there's reporting from the health department based on data collected from recovery residences in the state participating in the program. This expands the list of reasons that a resident could be immediately exited or terminated from a recovery residence program. And as I said, it also removes the sunset that exit policy that's currently in place. So those are some of the big items.
Can you just say what that exit policy means for the resident?
Yeah, I think we'll have to look at it. It's a long section.
Yeah.
So, I want to say 2 years ago, there was a big conversation about where we were with recovery residences. There was a conversation that certification would be coming, but wasn't here yet. And this language was sort of, to fill a gap until we, were further along in the certification, question. There is a long section of existing law in this bill that requires recovery residences to have residents sort of fill out an agreement and be made aware of all different types of issues related to the recovery residents. Specifically within that is the reasons for which they can be terminated, like certain criminal activity. And this expands that list, and we can look at that, and I will highlight it for you when we get there.
I think that is problematic for some folks in the field. That this was expanded. So,
That's why we're looking at it.
yeah.
That's why I asked the question.
Yeah, you're right. Yeah.
Okay. So our first section is setting up the certification. Again, I'm gonna try to stay high level.
There you go.
Which is very hard for me. So we have a definition of recovery residence. And then we get at the top of page 2 into the certification language. And I said there are all different criteria that have to be met to be able to have receive the certification from the health department. So that's what this list is here, all the different items that have to be met or achieved by the recovery residents to receive that certification from the health department. I will refrain from going through the list. And then one of them is that the applicant has to comply fully with 9 VSA chapter 137, which is our residential rental agreement chapter. There's language about how to renew a certificate annually through the department. Here is our rulemaking language that the department has to set up rules for this certification process. And then we have a reporting section that requires all the certified recovery residences to provide certain data to the health department every year. And with that data, here's all the data that has to be submitted right here. And then with all of that data, the department is to compile a report for the General Assembly of February of each year. So they have about a month to put that data together to submit to the General Assembly. So that is the new language with regard to the certification process. This section 2 is the language I have been referring to that is currently an existing law, but it's time limited. It's going to be repealed. This subsection B would be repealed as of July 1, 2026. And we will get to it, but the proposal is to not repeal it. So this is language says, notwithstanding these 3 subsections and rental residency law, a recovery residence may immediately exit or transfer a resident if all of the following conditions are met. So one item is that the recovery residence has developed and adopted a residential agreement. And that agreement has to identify all these specific terms. They have to contain a written exit and transfer policy. They have to explain program rules and expected residential social standards. That's new language that's being proposed. The residential agreement, this is what you're looking for, would specify that by signing a residential agreement, a resident acknowledges that the recovery residence may cause the resident to be immediately exited or transferred to alternative housing if the resident violates the recovery residence's substance use policy, regularly refuses to engage in services or programming, commits a crime, engages in theft, is mentally or physically interfering with the recovery of other residents, or engages in acts of violence that threaten the health or safety of other residents or recovery residents' staff. So you can see that the language that is highlighted is being proposed as an addition to the existing language that's been in effect for about a year. And then that language is mirrored again here, so that the person would have to acknowledge that if they violated the substance use policy, and then this whole list, that they could be immediately terminated or exited from the program. Let's see, and then we have a definition of recovery residence that just cross-references the definition that's being established in section 1. So here is our sunset. So we will have, this would sunset the language we just looked at in subsection B on July 1, 2026 by striking it out. We are saying this language would stay in place. There would be no sunset. The language would stand with the additions proposed. What would still be sunset is right now there is a 2-year report. I didn't say that clearly. There is a report, an annual report for 2 years about recovery residents exit and transfer data that was meant just to capture the time period where this sort of interim language was being used. So that would go away, and that reporting requirement would go away, and what would replace it is the certification report data that we looked at in section 1. So you might want to look at the report and see, is this a report that you want specifically on exit and transfer data, or is the new report in section 1 going to be sufficient to meet the needs of the committee?
So when we start going through the bill, we can do that.
Yeah.
No, we should.
And this takes effect July 1, 2026.
Okay, so. And I know the Department of Health has talked with me and shared some recommendations for language change that we should look at, and just for your here. I appreciate you doing that, and I've shared those with Katie, so we'll, as we go through the bill more in depth and understand exactly what's there, we can listen to see what the Department of Health's recommendations are. And I will say that the Deputy Commissioner and others have worked very hard in this area, so see what their thoughts are. Any questions for Katie on this?
Can I say a comment? Can I share a comment this Friday morning? I'm one of the co-sponsors of the bill, but I am concerned, you know, after having signed on and speaking to people in the field, that it is potentially unnecessarily punitive, and I just want to make sure that we look closely at the language. And
You're talking about the
the expansion of reasons to be exited, I'm a little concerned about. So
well, yeah, we'll hear from Barb. We'll hear from the recovery residents folks. Hear from folks who are in the field. We'll have to do that. Make sure that we got them in, and then understand what it means for people, patients, others. And there are different levels, remember. So it's, you know, it's not like
right.
this covers all residents. All of them.
Yeah.
So there may be a totally different story at level 5 from what it is at level 1. Right. Yeah. So I think it's a more nuanced discussion than probably the bill has. Could be. Okay. And so can I ask Jessica, do you want to speak to the bill at this time, just briefly, or?
I think we can wait until there's the full walkthrough on Wednesday and then we do our testimonies.
Okay.
We'd be
All right.
happy to do
Good.
that. But
Yeah.
thank you for the
Yeah,
opportunity.
well, thank you. Thanks for that. And we appreciate you sharing what you had with us. Okay. Is there anyone else who wants to offer comment? The room is filled with people who are here. And I haven't done this with 241. So if you have a comment to make about either 241 or 157, if you'd like to do that, just raise your hand. Okay.
Stephanie Winters. I am the Deputy Director of Vermont Medical Society. I don't have a comment on this one. I think the comment made by the new senator about 241, just looking into some of the ramifications in practice of use of AI, because I know, and again, this is off the cuff, but I know that Up to Date, which is a software that a lot of practitioners use to get scientific medical information, now has an AI function. And so making sure if they use that informing their treatment plan or, diagnosing, that is not prohibited by this bill. So just flagging that for myself, that I need to look more into that and making sure that, as Katie said, that wouldn't be prohibited, but just really flagging to make sure that's, and we'll come back and talk to you.
Good, that would be great. And I mean, ultimately our goal is to hear from a practitioner or two, so we can understand basically what the request would be on that.
Yeah, but we do appreciate the bill, obviously, for its protections.
Thank you.
Meg Post Action Circles, I'll be real brief on this bill. I represent Recovery Partners of Vermont, which includes all certified recovery residences in the state, as well as the recovery centers. And they are all in strong support of this language. And I encourage committee members, if you're curious about the language, to connect with your local recovery center about why it's important.
Good. So we can get some practitioners and we can get some.
Yes.
Okay, thank you. Anybody else? Good. All right. You are a captive ledge council right now.
Yes,
What,
I'm awaiting an email that I'll be back into the floor.
we are on to, oh wait, so can you see if Copper McFawn is available? Because he's the sponsor of the next bill. And before he comes in, what we can just jump over to, no, that would be a good idea. We could jump to autopsy,
Okay.
but Senator Hardy's coming in later, so we won't do that. She's gonna do that.
But it's 2:06.
Hold on to that.
Hold on to that one.
Okay, and 206 is huge, so it's not diving into that.
Okay.
Let's just take a minute and see if, Representative McFawn is available.
Okay.
We'll go off live for a minute. I'll do that.